So launching into the first talk, we have Giuseppe Ferrandino from Owlstone Medical, and his talk title is Gut Microbiota Profiling via Dynamic Breath Analysis. So after completing his PhD, Giuseppe embarked on a postdoc journey at Yale School of Medicine in the US, with his research focusing on membrane transport and non-alcoholic fatty liver disease. Giuseppe then joined the Max Planck Institute in Germany, with his research focusing on two genes associated with the accumulation of fat in the liver. And now Giuseppe is utilizing this knowledge at Owlstone as part of the hepatology program, providing valuable scientific support with the objective of developing non-invasive tests for liver disease. So over to you, Giuseppe, and we'll have time for questions at the end.
Hello, my name is Giuseppe. I am a senior translational scientist at Owlstone Medical, and today I'm going to talk to you about gut microbiota profiling via dynamic breath analysis. The gut microbiome feeds on the nutrients that we ingest with our diet, and these nutrients can be converted in beneficial or deleterious metabolites. For example, carbohydrates can be converted to ethanol and 2,3-butanediol, that are two compounds found associated with non-alcoholic steatohepatitis. This is a chronic liver disease that can lead to cirrhosis and is characterized by inflammation and accumulation of fibrotic tissue in the liver. And if it is not treated promptly, it can lead to liver failure. Other compounds that are associated with chronic diseases are, for example, choline, which is an important metabolite and an important nutrient in our diet, which is converted to 3-methylamine, and then in the liver it's converted to 3-methylamine N-oxide, which is a compound found associated with cardiovascular diseases. There are other compounds, for example, methanol, acetaldehyde, and ammonia, that can be associated with neurodegenerative diseases. For example, if we consider ammonia in subjects with cirrhosis, this compound can lead to hepatic encephalopathy, which is a cognitive defect due to the incapacity of the liver to remove this compound from the blood. As we can see from this slide, several compounds produced by the gut microbiome are volatile organic compounds, meaning that they can be measured in the breath, and therefore we can exploit accessibility of breath collection to characterize the increase of these compounds in breath after substrates administration. And of course, this can be clinically very important, and we can see some example here for measurements that have been performed in blood. So for example, here on the left, we can see a study that was published in Nature Medicine in 2022, where subjects with NASH were treated with 4-methylpyrazole, which is an inhibitor of the alcohol dehydrogenase. This enzyme is the main involved in ethanol metabolism in the liver. We can see here that before carbohydrates intake, the subjects showed very small amount of ethanol in their blood. However, after carbohydrates intake, NASH subjects, shown by this blue line here, showed a spike after administration. And we can see the time course here up to 250 minutes, in which the ethanol was measured at different time points. So, interestingly, subjects without NASH, so the controls, didn't show or show a very little spike after carbohydrates intake. However, the same NASH subjects, when they were treated with an antibiotic that killed all the gut microbiome, so these subjects showed no spike of ethanol, indicating that the microbiome is the main component involved in glucose conversion to ethanol. So another interesting compound is 3-methylamine N-oxide, which is generated from 3-methylamine in the liver, and then 3-methylamine is generated by choline conversion in the gut. These compounds have been found associated with increased cardiovascular disease, and at the preclinical level, it has been shown that 3-methylamine N-oxide increases cardiovascular lesions size in a mouse model prone to develop cardiovascular diseases. And we can see that actually all of the compounds in the pathway, choline and trimethylamine and oxide, are involved in this increase in cardiovascular lesions. So, if we focus on ethanol production, for example, we can see that treatment of non-alcoholic steatohepatitis is under development, and therefore there are several drugs that have been experimented. Some of these drugs are still ongoing in their clinical trials, and some studies were terminated because the drug showed side effect or lack of efficacy. In general, these drugs try to correct processes such as inflammation, oxidative stress, and apoptosis. And these processes are all exacerbated by ethanol, meaning that if there is an excessive ethanol production in the gut, it may be that this ablates the beneficial effect of the drug, and therefore reduces the probability of having an improvement after the drug treatment. For this reason, also, subjects that are enrolled in clinical trials are strictly controlled in terms of ethanol production, and usually they may be tested for how much they have been drinking. However, there are no current tests performed to see how much ethanol these subjects produced in their gut. So, now, what are the consequences of this lack of stratification? So, it has been reported that up to 60% of subjects with NASH are ethanol producers, meaning that they have these bad bacteria in the gut that produce ethanol. This ethanol may reduce or ablate the beneficial effect of the drug, and this means that the remaining part of the cohort that doesn't have these bad bacteria must show a very high effect size for the clinical trial to meet the endpoint. So we can hypothesize that if we control for ethanol exposure, either the one taken with the diet, but also the one generated by the gut microbiome, this may help to meet the endpoints in phase 2 trials and enroll better cohorts in phase 3 trials, increasing chances of success. However, so far there is no available diagnostic test to identify if a subject has excessive ethanol production from the gut. Now, in general, if we take a step back, the current methods that are used for studying the gut microbiome are metagenomic, transcriptomic, and proteomic analysis of material obtained from the human gut. So, this presents some limitations. For example, except feces, other specimens are collected with invasive methods. Feces do not represent the composition of different parts of the gut, and genotyping may not provide accurate information about the phenotype of the microbiome. Other methods are steady-state metabolic measurements of blood, stool, and other specimens. However, as we have seen before in the example for ethanol, differences may be very subtle between disease and healthy population because the bacteria in the gut do not have a substrate to work on and produce these metabolites. So another approach is the one that I showed you before, metabolites measurement in blood after a nutrient challenge. However, so in this case, the substrates are provided to the gut microbiome, and the response in terms of metabolites production can be measured. However, we need to collect blood at several time points, either before and then after the substrate's ingestion, and this reduces the compliance of the subject. And of course, all of this reduces the scalability to large cohorts for a better characterization of this kind of responses with chronic liver diseases association, and also for follow-up effects on diseases progression. Other methods are functional annotations and culturing. So inferred function from the genomic data may not represent reality, and culturing may not reproduce physiologic conditions and can exclude difficult to culture species. And therefore, we can partially overcome these problems by using breadth analysis, because we can exploit the accessibility and feasibility of breadth analysis because we can easily collect a sample before and after substrates administration. There is possibility of targeting specific gut sections based on provided substrates. For example, carbohydrates that are digested more slowly can be administered, and then we can collect breath later on and measure the metabolism in more distal parts of the gut. Then there is increased compliance for the participants due to the non-invasive nature of breath collection, scalability to large cohorts, and potential for at-home testing. So we can characterize the subjects even before they have been enrolled in a clinical trial, for example. So initially we focused on ethanol and 2,3-butanediol fermentation because these two compounds have been found associated with non-alcoholic steatohepatitis, as I showed you before. And in particular, I would like to point here to acetoin. Please remember this metabolite that we are going to see later in the results. After this pilot study, then we also started to explore additional substrates, and I'm going to show some preliminary results about those as well. So this is the study design and the protocol for the subjects. So we enrolled for the glucose administration, we enrolled 10 healthy subjects, 18 years old or higher, more than 50 kilogram of body weight, BMI was below 28 kilogram per square meter, and then they were reporting no known liver diseases. The protocol was to fast for more than 10 hours, usually we do overnight fasting, avoid alcohol the day before, and then avoid confounders on the day of the experiment, such perfumes, lipsticks, etc. So we we analyzed the breath by using SIFT-MS, so we collected several ambient, and then breath samples were collected with direct sampling, meaning that the subject was blowing straight into the machine. So we collected baseline from the subjects, meaning before they ingested glucose. Then they ingested 75 grams of glucose, and then we performed the post-administration breath collection for 90 minutes, every 5 minutes. Each breath sample was represented by 3 exhaled of around 15 seconds each, which were averaged, and they were consecutive exhaled more or less 1 minute far away one from the other. And then we collected also additional 3 samples, exhales of 10 seconds for untargeted analysis. However, now I'm focusing on the results that we obtained with this targeted approach. So these are the subject's characteristics. And then we can dive into the results. So we can see here a box plot comparing the ambient that we measured before and after every experiment for every subject, and then the breath of the subjects at baseline before glucose administration. So we can see here the amount of ethanol in part per billion, and clearly we have ethanol production even after an overnight fasting. But then when we administer glucose, we can see that, so this is the time on the x-axis, and then we have the amount of ethanol in ppb on the y-axis, and every panel represents one subject. So we can see that ethanol induces a spike, glucose induces a spike of ethanol in breath after administration, and we can see that the scale vary between the subjects, indicating that this is a very personalized response. And also the width of the spike is quite different between the different subjects, suggesting that this is a very individual response generated by the gut microbiome, which is very well characterized to be highly variable between different subjects. Similarly to ethanol, we also measured acetoin, which is an intermediate of the 2,3-butanediol pathway that I mentioned before. Again, we see elevated levels in breath compared to the ambient. And then we observed a spike after glucose administration in all the tested subjects. And again, there is a bit of variability on the y-axis about the extent of the response. We also measured a spike of propanoic acid. Again, we can see here that it is elevated in breath compared to the ambient. And then there was a spike in 7 out of 10 subjects. So this is a box plots for several of the compounds that we have been measuring in breath, and then a comparison with the ambient collected for each subject. We collected acetone as a positive control because this is a very well-known compound exhaled in breath. Then we measured 2,3-butanediol, which is that I showed you before is associated with non-alcoholic steatohepatitis. Pentane, hydrogen sulfide, acetic acid, methane, methanol, trimethylamine, acetaldehyde, and phenol. And we can see that all of these compounds showed higher level in breath compared to the ambient. So, as I mentioned before, besides glucose administration, we have also experimented additional compounds, and we are in the process of recruiting further subjects. So it is very well characterized that amino acids can be also metabolized by the gut microbiome, and they can produce specific bioproducts. For example, if we administer tryptophan, we can see a spike of cresol here on the left, and then a spike of phenol, and we have observed these in 3 tested subjects so far, but we are planning to expand this cohort. And for example, if we administer cysteine, we also observed a spike, although this is quite an earlier spike, which may be generated from the mouth. And if that is the case, I mean, it still will be an interesting compound to follow up, because there have been reports of bacteria that from the mouth travel down into the intestine in subjects with NASH, indicating that there is this translocation that is associated with the disease. So, in summary, these are the compounds that we measured in breath so far, and most of these have been reported to be generated by the gut microbiome. And this is a panel that can be used to measure with and without a substrate challenge to characterize the association of the response of these compounds with the specific diseases. So, in conclusion, so we showed that fermentation products can be measured after a glucose challenge in breath. Several additional gut-derived metabolites are detectable in breath as well. Amino acid metabolism generates volatile compounds that show a spike in breath after administration. So our next steps are that to use dynamic breath analysis to investigate association of substrates conversion mediated by gut bacteria with disease of interest, explore ethanol fermentation in NASH populations to establish association with disease severity and progression, using also additional carbohydrates that are less absorbable. So yeah, one experiment that we plan to conduct is to try oat powder, which contains carbohydrates that are at medium absorption, so they should stay in the gut for longer time. And so that concludes this talk. I would like to acknowledge the colleagues that helped to conduct this study and are still helping to conduct the additional studies that we are performing. And of course, all the participants that enrolled the study as volunteers. And thank you very much for your attention, and we are happy to take questions.
So we've got a few questions coming in. Quick reminder to everyone, post it in the Q&A button, not the chat button, please. First question, I think you kind of touched on this a little bit already, but it's looking at the time when you get the maximum, so the Tmax time. So are you able to distinguish between microbiome-derived signal versus oral microbiome-derived signal? I was wondering if you could comment further on that.
Yeah, so that is a very interesting aspect to cover because, yeah, it would be nice to have an approach that allows us to dissect the different parts of the digestive system, starting from the mouth, going down up to the large intestine. And so we can do that using different approaches. One approach that we tried is to just having people swishing glucose in the mouth and then spitting it out. And basically, we can see that the the oral microbiome contributes to those signals. And so basically, we observed some subjects that were giving an early spike overlapping with what we have observed for ethanol, and then other subjects that were having this early spike, but then this was not overlapping with the spike observed when there was ingestion. And for example, for propanoic acid, we just observed a sort of a flat line compared to the ingestion, suggesting that to see the spike, although it's early, it needs ingestion for elicit the response.
Okay, very interesting. And actually, the next question touches on a point that you mentioned there as well. So when administered substrates are absorbed quickly, you can probe mainly the proximal part of the digestive tract. How do you probe more distal regions?
Yeah, so as I mentioned, we can use carbohydrates that are more resistant to be absorbed. And for example, oat is reported to be composed of carbohydrates that are digested more slowly. So they should make more down into the gut, and then we are going to assess this as well.
Brilliant. Yeah, and yeah, next question, that basically saying what are the insoluble carbs you're planning to use, and what's the advantage compared to glucose? I think obviously testing different bits of the GI tract.
Yeah, we can try even carbohydrates that are not absorbed at all. Like one of these is lactulose. Maltodextrins also should be not absorbable, and see if those are used as substrates for fermentation.
Brilliant. Maybe you mentioned, but what was the time resolution of the measurements?
Yeah, so we collected breath every 5 minutes. So, yeah, it takes more or less 1 minute for providing the breath and performing the analysis. So basically, we could push this down to a resolution of, let's say, 90 seconds. We haven't done it because then would have been too much of a burden for the subject. And then we implemented also some additional collections that were for untargeted analysis, and that's another story. But yeah, basically in theory, we could do like 90 seconds resolution.
Fantastic. So some compounds are produced either by the body or the microbiome. How do you discriminate between the contributions?
Yeah, so what we can use the same approaches that have been used for other compounds found associated with diseases. For example, ethanol or trimethylamine N-oxide pathway, where so they were found associated with the NASH and cardiovascular diseases, and then the subjects were given antibiotics. And then it was shown that the response was completely gone after antibiotics treatment. And that can help to discriminate the extent coming from the body and the extent coming from the microbiome.
Fantastic. Is it possible to measure ammonia on breath using this approach? It's one of the questions.
Yeah, so with SIFT, we have been successful in measuring ammonia in breath over the blank. So yeah, using SIFT MS, we are confident that we could see an ammonia signal over blanks. But yeah, this was mainly in healthy subjects. It will be interesting to assess this approach also in subjects that have a liver disease where ammonia levels may go higher and cause hepatic encephalopathy.
Yeah, brilliant. Next question is, was 5 minutes enough to restore the equilibrium of the gas components? Could some dilution effect at this short time between sampling?
Sorry, can you repeat?
Yeah, it's not super well phrased. I think it's about, is the 5 minute interval long enough to equilibrate back to the same concentration essentially on breath?
Yeah, we found, with the system, that time period was enough to perform all the analysis and then getting the system back up and running for the next sample.
Next question is there a high difference between the 3 samples of the same individual collected every 5 minutes?
No, there are some fluctuations, but basically they falls within the same range. So I plotted the data without making the average, and basically the shape of the profile doesn't change.
Got it. And then next question relates to breath volume collected. I may have missed it, but what was the breath volume? Was the breath volume controlled per subject, or is the breath sampler a controlled volume? So obviously it's a SIFT, so it's a direct analysis.
Yeah, so it was a 15 seconds exhalation, and then the flow rate was 20 ml per minute. So the time for the analysis was constant for each breath sample, and therefore the volume was fixed based on the rate.
Excellent. And then time for one last question. What proportion of the gut microbiome is fungal?
Oh, yeah, that's a nice question. So basically, it has been shown that subjects with autobrewery syndrome have basically they have these fungal presence in the gut, and then they may produce very high amount of ethanol, although the reports are very limited. And these subjects were producing so much ethanol that they were getting drunk after every meal. They could not even drive. And most of them were identified by basically just because they were given an alcohol test while they were driving, and then they found out that they had fungal infection in the gut.
Interesting. I suppose, one question or observation is, so do you think it makes sense then, if you're running NICE trials, to routinely try and measure ethanol levels?
So it has been shown that in subjects with non-alcoholic steatohepatitis, even exposure to small amount of ethanol can increase the risk of having liver events. And therefore, so far, the contribution of the gut microbiome in ethanol production has not been characterized in those subjects. The focus has been mainly on how much ethanol they drink. But basically, probably that's something that should be checked in those patients to make sure that their liver is not exposed to high amount of ethanol that may increase the risk of having liver events. Even though they don't drink at home, but maybe just consumption of sugar could cause them problems.
Excellent. Thank you so much, Giuseppe. We've got to leave it there and move on to the next speaker, but thanks again for taking part today.